This presentation is on juvenile fibromyalgia syndrome. It's presented by Crystal Lucas, a student at the University of Missouri, St. Louis. Juvenile fibromyalgia syndrome, also known as JFMS, is a chronic idiopathic pain syndrome characterized by widespread pain and fatigue. Fibromyalgia is more commonly found in women over the age of 18, which makes it very difficult to diagnose in children, as symptoms can be vague and very episodic. Juvenile fibromyalgia syndrome is a part of the musculoskeletal pain syndrome class. JFMS affects 1 to 7% of all children, and in pediatric rheumatology clinics, it accounts for 7 to 35% of all patients. This syndrome is more often diagnosed in girls, especially between the ages of 13 and 15, and family environment seems to be a very big predictor of diagnosis. So what causes JFMS? Well, that is still unknown. Possibly genetics, such as autoimmune family histories, or environmental factors. More recent theories seem to link genetic and environmental factors into an abnormal transmission of pain stimuli that affects the child. In assessing for JFMS, patient history is a key tool in the primary care clinic. The history of current illness reveals pain that has lasted more than 3 months, and it can be described as an aching, a burning, a tenderness, or a stiffness of the muscles. Other common symptoms include fatigue, difficulty sleeping, anxiety and/or depression, stomach aches, headaches, memory problems, and dizziness. A good social history often uncovers the presence of stress in the child's life that may exacerbate symptoms of fibromyalgia. Next, the practitioner should perform a very thorough physical exam. The symptoms associated with JFMS require a complete head-to-toe assessment. A focused musculoskeletal exam may reveal joint swelling, joint stiffness, or a hypermobility of joints. With the palpation of muscles, trigger areas of soreness are detected. These can be circumferential or linear in pattern, and pain increases with pressure. These are some of the more common areas of tenderness in a JFMS patient. Most are at tendon insertion sites, including the neck, back, and knees. Diagnostic testing for JFMS is used to rule out other possible diagnoses. This includes CBC, a rheumatoid factor, AST, UA. The differential diagnoses for JFMS is very extensive. Possible differentials include juvenile arthritis, lupus, thyroid disease, multiple sclerosis, tendinitis, growing pains, depression, and pediatric hepatitis C. Ultimately, the key to diagnosis is ruling out other possible disorders and diseases. Diagnosing juvenile fibromyalgia syndrome. At this time, there are no pediatric diagnostic criteria. Many times, adult diagnostic criteria are used, most often the exclusion of other disorders. Next, we will explore the management strategies for JFMS. 4 main areas of focus: education, physical exercise, psychotherapy, and pharmacology, all are aimed at controlling pain and psychosocial effects. Education to patients and family include that this is a chronic disorder that there is no cure for, but there are periods of remission and exacerbations with this disease. A focus on education needs to be on worsening symptoms that may be due to stress, fatigue, illness, weather, or other identified triggers. Physical exercise is important in the management of JFMS because it regulates pain, it decreases fatigue, and it decreases sleeping problems associated. Plans should include moderate to low-impact exercises. The plan needs to be individualized so that patients keep going, and physical therapy may be necessary. Psychotherapy is also necessary in the management of JFMS. Cognitive behavioral therapy is most often utilized. Goals of therapy include teaching modified thought patterns, coping skills, relaxation techniques, but ultimately increasing pain control. Pharmacology therapy is questionable. There's no current FDA-approved treatment. NSAIDs tend to be first choice, followed by skeletal muscle relaxants and tricyclic antidepressants. Gabapentin is a first-line treatment for adults with fibromyalgia. However, it is not FDA-approved for children with JFMS, though practitioners do utilize it as a last chance. This diagram is a great overview for the treatment options for JFMS. As a practitioner, there are other considerations that need to be made for patients with JFMS. Symptoms compound on each other, worsening the pain. The pain increases fatigue, which increases lack of exercise, which increases more pain. It's a cyclic factor. The pain associated with JFMS has been known to cause severe social isolation. This can be greater than that of childhood cancer patients. Overall outcomes vary greatly between children with JFMS. Many do persist into adulthood. However, there is a better prognosis in the pediatric population. In review, JFMS is a rare disorder causing chronic pain, with periods of remission and exacerbation, social isolation, and multiple treatment strategies. Let's see how much you learned. Let's review with some questions. What pediatric population is most at risk for JFMS? That's right, girls 13 to 15 years old. What are the goals of treatment for JFMS? Awesome job. Pain control and psychosocial symptom management.